chapter 16, our final chapter for this semester, I should say. Okay. So let's talk a little bit. Of course, it seems like we've really been inundating you folks a lot with information regarding the nervous system. So we're going to kind of continue on with that and talk about sensory information. And last chapter, when we were talking about the autonomic nervous system in chapter 15, we really discussed a lot of the motor aspect, you know, the motor command output, and then the various effectors and those pathways that took us in that area. But we really haven't talked too much about the sensory input. So we're going to kind of focus on that here in this last chapter. So sensory information is going to be that information that is going to occur in our external environment, in our internal environment, that is going to be collected by receptors out in the periphery and then transmitted up to our central nervous system, to the brain. So how do we get that information there? Okay, we're going to utilize sensory neurons that are going to transmit all of that sensory information that was collected by our receptors. And we're going to learn tonight all the various receptors that are going to collect that information and provide it to our central nervous system. So this chapter is basically going to focus on some of those different sensory information stimuli. So we're going to talk about touch, taste, hearing, all right, sight, smell, and then equilibrium. Sometimes it's referred to as balance. And then we're going to talk about how we classify, all right, some of the ways that we collect this information or this data. So let's review. Sensory receptors are going to be these structures that are going to provide your nervous system, mainly your central nervous system, information about what is going on outside of your body and what is going on inside of your body. Now, all sensory input is a result of a stimulus. So we need a stimulus to occur to trigger the receptors to send that sensory information to your central nervous system. And what we found out is that certain receptors are going to be able to respond to certain types of stimuli. For example, all right, light energy is going to be collected by the photoreceptors in your eye. Great. Those photoreceptors are great for collecting light energy information. They are horrible for collecting sound energy information, right? In fact, they don't work at all. So specific stimuli are going to trigger or activate specific receptors. So we see the sound energy receptors are going to be in your inner ear, all right? And so we won't have that same amount of, what's the word I want to use? Success when we are trying to process information unless that receptor is specific for that stimuli. So we have to actually, and staying on that kind of that subject when we're talking about light energy and sound energy, all right, ideally, all right, these different types of stimuli, this light energy and sound energy, we want to process that information into nerve signals to our central nervous system. So we have these structures, we call them transducers, and these transducers are responsible for converting the energy of a specific stimuli. It could be pressure, it could be light energy, sound energy, it could be chemical interaction, but it's going to convert whatever that stimulus is into an action potential. And that's what transducers do. So when there's really nothing going on and your receptors are at rest, right, the membrane potential of those receptors, right, are at a specific level. And then what happens is a stimulus occurs and it's going to alter that resting membrane potential. It's one of two ways. It can hyperpolarize your membrane potential or it can depolarize the membrane potential. But not all receptors are going to have, all right, the protein gates that we saw before in previous chapters when we were talking about muscles and neurons. Right? We briefly discussed it in chapter 12, how we have what's called modality gated channels. And these modality gated channels are another type of channel in the membrane that will allow, all right, the movement of ions across the plasma membrane, all right, to respond to whatever that stimulus is. So when we talk about a modality gated channel, for example, it could be a pressure channel in which a certain amount of membrane distortion, okay, from pressure, like just pressing your finger into the back of your hand, for example, right, that will trigger a distortion in the plasma membrane, and that will cause those modality gates to open up, and then ions can flow across, and then we can alter and change our resting membrane potential. And so then we generate our action potential, that nerve signal, and then that nerve signal, you know the rest of the story, the receptor then sends that sensory input information up to the central nervous system, so the central nervous system can process that information. So when we're looking at, all right, our sensory receptors, we have to talk about a receptive field. This is more so, all right, for the tactile sense. But when we're looking at the receptive field, we're going to see, all right, that our receptors are going to send the nerve signals to the central nervous system through sensory neurons, not through motor neurons, but through sensory neurons. So when we're discussing what a receptive field is, we're going to see the textbook definition is the distribution area of the endings of a sensory neuron. So the sensory neuron on one end, okay, you're going to have the axon, which is going up to the central nervous system. And at the other end, you'll normally have a process, usually a dendrite, that extends out into the periphery somewhere. And at the end of that process, you'll have these small little endings that come off. So if we zoom in here at this picture down here at the bottom, you can see what I'm talking about. Okay, so here you can see you have your sensory neuron, then you can see how it has these little processes at the end. And so what happens is with those processes, right, they'll collect that sensory information. And so we find out that if the nerve endings are in a relatively small region, right, that will give us a small receptive field. And a small receptive field allows us to localize exactly where that stimulation occurred. Whereas a large receptive field, right, that sensory neuron can have many, many processes or nerve endings there that are coming off over a large area, right, of the skin, let's say. And so if that sensory neuron gets activated, you will have a general idea of where the stimulus is, but because it's a large receptive field, it's going to be a little bit more difficult to locate the precise area of where that stimulus occurred. So a small receptive field gives us more of a precise location for the stimulus. A large receptive field will not give us as much of a precise location for our stimulus there. So this next concept, when we talk about sensation, is very important. There have been multiple test questions asked about this. So I really strongly urge you to, now watch when you take a test, you won't have any, but what I'm saying is the concept of a sensation is going to be when we become consciously aware of a stimulus. Right? And the way for us to be consciously aware of a stimulus is when that nerve signal travels all the way to the cerebral cortex. Before it gets to the cerebral cortex, right, it has to go to the thalamus. Now, not all sensory pathways lead to the thalamus. The olfaction, smell, does not go to the thalamus. That's the only one that does not go to the thalamus. But this applies to everything else. So touch and taste and sight and sound, all of that sensory input will go to the thalamus. From the thalamus, right, the neuron will travel to the appropriate location in the cerebral cortex. Once it gets to the cerebral cortex, that's when you become aware of whatever the stimulus is. So if you have a nerve signal traveling up your spinal cord through the brainstem and it stops just before it gets to the thalamus, or it never makes it past the thalamus, you won't have conscious awareness of that. And only a small fraction of stimuli information ever makes it to the cerebral cortex. I was taking a neuroanatomy class in med school, and I had a professor, and he said, when we were talking about this concept, he said that if you were consciously aware of all the sensory input that came from the bottom of your feet when you were standing, you would go crazy. Right? There's so many nerve endings in our skin, and there's several down in your feet. And a lot of that sensory input does not make it to the cerebral cortex. And for good reason. It would be a sensory overload and we wouldn't be able to function. So it really depends, all right, on how that pathway is designed, but also, all right, the actual, what's the word I want to use here when we're talking about the stimuli? How strong, I should say, the stimuli is, right? Think about it. And well, actually, I'm jumping ahead of myself. I'll get to that concept here in a moment because I had a really good point to make, but we're going to come up to that in a moment. So what we do know is a lot of sensory input, all right, that enters into the central nervous system isn't always going to go to the cerebral cortex, right? It might arrive only at the brainstem, and we know what is located in the brainstem. A lot of our visceral reflex centers, okay? So when we talk about cardiac output, like your heart rate, respiratory rate, blood pressure, our vasomotor centers there, right? You have lots of control centers for visceral reflexes in the brainstem alone. And so a lot of changes that occur in these areas here, especially if we're talking about vasomotor control or cardiac output, right, you're not aware when your blood pressure goes from 120/80 to 122/84. Right? You're not made aware of that. You don't know when your heart rate goes from 80 beats a minute to 85 beats a minute. Right? So a lot of these things, these phenomena occur below our level of consciousness. So what I'd like to do now is talk about how receptors are going to provide our control center, our central nervous system, with information about a stimulus. And there's four categories in which these receptors are going to tell our central nervous system, all right, what type of information about a stimulus. One is modality. That's the type of stimulus. Two, where this is happening. All right. Three, is it mild? Is it a moderate or severe stimulus? And four, duration. How long? How long is this going to last? How long is this going to happen? If I'm in pain, all right, I don't want to be in pain for a long time. So how long is this going to go on for? So the first type, all right, of category that we talk about for our sensory stimulation has to do with modality. And this is the type of stimulus. So this basically is based upon when that nerve signal comes in from the receptor, where does it go in the brain? If that nerve signal goes to the occipital lobe, then we know it's a visual stimulus. If that nerve signal goes to the insula, then we know it's a taste stimulus. Or if it goes to the temporal lobe, we know it's smell or hearing. Right? If it goes to the somatosensory cortex there in the parietal lobe, then we know it's a tactile or touch stimulus. Right? So basically, we're going to figure out the type of stimulus, right, is dependent really upon where that nerve signal is going to travel to. All right, our next category is the location of the stimulus. Where is this happening? Well, this is where we talk about that receptive field there. Okay, if it's a small receptive field or a large receptor field. But for example, let's talk about touch, real easy. Okay, you are touched somewhere on your skin. Okay, that information is going to travel up to your somatosensory cortex in the postcentral gyrus. You recall that sensory homunculus, that distorted image of how your brain perceives your body? Well, if you were being touched on the heel, okay, that sensory information travels up that nerve pathway and it'll wind up in the appropriate area of the postcentral gyrus that is allocated for the heel, right? If you're getting touched on the face, then that sensory information winds up on the sensory homunculus in the postcentral gyrus that is allocated for your face. So it really depends on what area of the postcentral gyrus, and this is how, all right, your brain knows, okay, where the location is of that stimulus when we're dealing with, for example, tactile senses. The intensity of the stimulus, all right, has to do with the frequency of action potentials that are arriving to the central nervous system. And how I kind of put that into perspective is if you're standing next to somebody and they are tapping you hard and repeatedly with urgency saying, we got to go, we got to go, we got to go, all right, then that is going to be a much more urgent or stronger type of stimulus that's going on compared to if you're standing there and a person just taps you and pokes you in the shoulder one time and then like a minute later they poke you again, they're like, hey, we got to go. That's going to be more from a mild stimulus. So the stronger the stimulus, the more frequent the action potentials are firing off. The more mild the stimulus, the less frequently those action potentials are getting fired off. So that has to do with the intensity. And then finally, we have to talk about, all right, our duration of the stimulus, how long? And that brings up adaptation. So we're going to see that over time, the receptors, depending on what type of receptor, if it's a tonic receptor or a phasic receptor, right, how it adapts. And what adaptation is, the textbook definition of adaptation is decreased sensitivity to continuous stimuli. So I like to use the example of a sock. You put a sock on, right? And they're brand new and they're tight. And so you notice that. But as the day goes on, or maybe even, after a couple minutes when you put your shoes on and you're walking around and you're dressed, right, you might not notice the tightness of that sock. And that has to do with, all right, the receptors in the skin that are covered by the sock adapting to that pressure from that tight sock. So when we break down the receptors, we talk about tonic receptors and phasic receptors. The tonic receptors, they have limited adaptation, which will be good in some cases. So they're going to respond continuously. So a perfect example is pain. You don't want to be able to adapt to pain. You don't want to get numb to pain, right? That's not a good thing. So all the pain receptors are going to be tonic receptors, right? So they are not going to display decreased sensitivity to the pain stimulus, which is good because it could be a life-threatening situation in that the pain is telling you you need to leave wherever you are to get out of that pain stimuli. We see it also with equilibrium. All right, we'll learn about this at the end of the chapter, but your head position, all right? So you have receptors in your inner ear that basically tell your brain the position of your head at all times. If you're looking straight ahead, if you're looking down, if you're looking up, if you're turning your head from side to side, right? All these receptors are going to send that information to your equilibrium center to tell your brain, all right, this is what your head is doing in relation to the rest of your body here. Right. And so we'll see that those receptors, right, have limited adaptation, which is good. Again, we don't want them to show decreased sensitivity, right, because we want them to be able to respond continuously to any changes that are occurring when you move your head around. The other type of receptors are the phasic ones. Now, these do adapt rapidly, right? This will be good. This goes back to my sock example, right? So when you put the sock on, and then over time, right, you notice that you're not wearing the sock, or you don't notice the tightness of the sock so much, and that's because those receptors have adapted, all right, relatively quickly. Now, if you were to take that sock off and then put an even tighter sock on, then, all right, these receptors would respond to that new tight sock. And you'd be like, oh, this sock is tight. But then over time, as you wore it, all right, those same receptors would adapt, all right, and then you become less sensitive to the tightness of that new sock that you just put on, the second sock. So a question for you. For a stimulus to be consciously perceived, the sensory input must be sent to what area of the brain? Folks, this is a question that I'd like you to type in your answer into the chat bar. So let me read the question one more time. For a stimulus to be consciously perceived, the sensory input must be sent to what area of the brain? Does anybody remember? So when we can consciously perceive a stimulus, that's called a sensation, but where does that information, all right, go in the brain? Here we go. Got at least two answers. Cerebral cortex. Yes, that is right. Very good. That is very, very good. Okay. Cerebral cortex. So I want to get into how we are going to classify our sensory receptors here. And how we do that is based on three different categories. All right, the categories are going to be where they're located, so where they're distributed, all right, where the stimulus originates from, and then what type of stimulus we're looking at. So let's start off with the distribution. There's two types. We have what's called general sense receptors and special sense receptors. General sense receptors are located all over the body. That includes your head, your neck, your feet, your legs, your arms, your abdomen, the thorax, everywhere. The other type, the special sense receptors, all right, they're going to be located only in the head. All right, so when we're talking about our five special senses, smell, taste, vision, all right, hearing, and equilibrium, all of those are located, all those receptors are located in the head. But when we're talking about general sense receptors, that includes the head and everywhere else in your body. So when we break down our general sense receptors, we have two categories. This should look familiar to you. Somatic sensory receptors and visceral sensory receptors. We talked about this back in chapter 12 when we were learning about the sensory component of your nervous system here. So the somatic sensory receptors, somatic, you should be thinking, all right, these sensory receptors are the ones that you can consciously perceive. So we're going to talk about our touch receptors located in the previous chapters. I've mentioned just the skin, but now we're going to start to include the mucous membranes. Those mucous membranes are going to be located in various areas, like in your nose, all right, in your mouth and throat. And then also the somatic sensory receptors include our proprioceptors. You remember the proprioceptors. Those were those receptors that we found near the joints and also the muscles and tendons around those joints. And they give feedback information, and it allows your brain to detect what your limbs and parts of your body are doing. And that's what those proprioceptors do for you. Now, the visceral sensory receptors, you won't have conscious perception of the visceral sensory receptors. The sensory input that they're transmitting, we don't know. All right. These are going to be found in the viscera. What's that? The internal organs there. And so these sensory receptors are going to monitor stretch, for example, like your stomach or blood vessels. When you get an increase in blood pressure, the blood vessels will start to stretch. All right. Chemical environment, that's taste and smell. All right. You start to eat something, all right, and you're tasting that food. All right, we're tasting the chemicals or the molecules of those chemicals, right, through our special taste receptors there. Temperature and pain, okay, those last two are obviously pain is very important in case there's damage going on to some tissues there. We need to transmit that information to our central nervous system, right, for a response, hopefully to protect ourselves. All right, so let's talk about the origin of the stimulus. This is the second way to classify our sensory receptors. And so we have three categories. Right? We have exterior receptors, interior receptors, and proprioceptors. The exterior receptors, exterior stands for receptors that are going to pick up the sensory information from stimuli that are outside of your body. Skin and mucous membranes do that. And also our special sense receptors. Vision, that's picking up everything outside of our body. Taste, same thing, even though we have some food or drink that's in our mouth that came from outside of our body. Smell, same thing, okay? So exterior receptors include your special sense receptors. The interior receptors are going to detect stimuli that are occurring inside your body with the internal organs there. So that's going to be a large amount of our visceral sensory receptors because they're constantly monitoring our viscera, what's happening inside. And then finally, our proprioceptors, right, these are going to include our movements of our body and the upper and lower extremities there. And we know that these proprioceptors are going to be located around the joints and the muscles and tendons of those joints there. And then finally, the last category for classification for our sensory receptors is going to be the modality, which is what? What is the stimulus? So we have 5 types, right, of receptors here. We have the chemoreceptors, the thermoreceptors, photoreceptors, mechanoreceptors, and one of my favorite, the nociceptors. All right, chemoreceptors are going to monitor chemicals, all right, in whatever it is that you are imbibing or smelling or whatnot. So they're going to take in information from the external environment when you are smelling something, but also, okay, when we're dealing with our internal environment, all right, we'll see the chemoreceptors monitoring, all right, certain levels of different molecules and compounds that are floating around in your blood, like carbon dioxide or oxygen. Right, we'll also see chemoreceptors active in taste and smell. Now, your thermoreceptors, we've talked about this way back in chapter 1. Right, we will see any changes in temperature, either too hot or too cold, but those receptors are going to be located all throughout your skin and even in the hypothalamus. Okay, that helps with, the hypothalamus helps to control your body temperature. And especially if there's some sort of infection going on, we can turn up the body temperature and induce a fever and hopefully cook off some of those offending agents there. But your thermoreceptors are going to be located right in both of those structures and constantly monitoring, because keep in mind, we want to make sure that our body temperature stays in that homeostatic range, that normal body temperature, right? 96.4 to 99.1. We want to try to keep our body temperature right in that range, usually around 98.6. And the thermoreceptors are going to give us that feedback information, or actually not feedback information, but they will provide that sensory input to our central nervous system so we can maintain that normal range. All right, photoreceptors have to do with light, but there's 3 things, right, that it monitors with light. One is the color, also the intensity, how bright or how dim, and then if there's any type of movement. And we find the photoreceptors in the neural layer of your eye, also known as the retina. Then we have mechanoreceptors, And so I was mentioning these types of receptors earlier on when I was talking about distortion of the plasma membrane there. And so the mechanoreceptors are going to be based on a lot of tactile sensations. So touch, pressure, vibration, and even stretch. And all of those stimuli, okay, will actually distort the cell membranes of these specialized receptors. And so they'll send that sensory information, right, to the central nervous system for processing. So when we talk about the stretch receptors, we refer to the baroreceptors, right? Proprioceptors, again, that's going to be for movement. All right, our touch receptors, that's pretty obvious. And then when we talk about our inner ear receptors, that's going to deal with equilibrium. Then finally, we have our nociceptors, our pain receptors. You have two types, the somatic nociceptors. This is going to be the nociceptors where you can consciously perceive pain. And so it's going to give us information on chemical, heat, and mechanical damage to the skeletal muscles or any body surface. And then the visceral nociceptors will deal with our organs. So question for you. Receptors on the tongue are classified into what three receptor criteria? Okay, so your tongue has to do with taste. So in order for those receptors to be stimulated, we need to bring something in from the external environment. So we're going to imbibe a liquid or food. And so those types of receptors are going to be considered to be exterior receptors. Since we're dealing with taste, that's one of our 5 special senses. All right, those receptors are going to be special sense receptors. And then finally, all right, when we talk about the type of stimulus, right, since we are dealing with food and liquid and everything that's starting to get mixed in with our saliva, right, and some of that food and liquid will dissolve into that saliva, right, the chemicals there from those food and liquid products will then stimulate the taste receptors there. So those receptors are chemoreceptors. So we're dealing with special senses, exterior receptors, and then chemoreceptors when we're talking about the receptors of the tongue. Okay, so I want to get into our first special sense, and that's going to be touch. So we're going to talk about our tactile receptors. Our tactile receptors are pretty much the mechanoreceptors that which we just talked about that are going to be located, all right, throughout the skin and in our mucous membranes. And so there's 2 types of tactile receptors, encapsulated and unencapsulated. And if you look down at that picture there, you'll see a lot of those different types of receptors located within the skin. So when we start off, I'm going to jump in and talk about the unencapsulated first. So unencapsulated means the sensory end of our neuron, our sensory neuron, all right, we'll see at the one end, usually we're going to be dealing with a pseudo-unipolar neuron here. So one end comes off the cell body and goes out to the periphery, and it'll have nerve endings. And that's usually the dendrite. This would be the dendritic end. And then the other process goes up towards the central nervous system, and that's going to be the axon. So at the far end in the periphery here, our dendritic end, when we're talking about unencapsulated tactile receptors, right, that dendritic end of that sensory neuron doesn't have anything covering it, no protective covering. So the first type we refer to as a free nerve ending. And so this type of neuron has multiple ends to it, these terminal ends there that come off the sensory neuron. Very simple, really basic. All right, we see them in the skin and in the mucous membranes, and they're primarily for pain and temperature. Pain and temperature. All right, but also we'll see their involvement with some light touch and pressure, but primarily it's going to be pain and temperature. So these types of receptors are going to be phasic or tonic, which means they'll either adapt relatively quickly, or they won't adapt, and so they'll continuously respond to whatever the stimulus is. Then we have our root hair plexes. All right, so a little bit of review. Remember the hair, okay? The hair that's beneath the surface of the skin is the root of the hair. The part of the hair that's above the skin, all right, that's going to be the shaft. All right, so our root hair plexes, we're going to see you'll have the nerve endings of our sensory neuron will wrap around the hair follicle. So whatever happens to the hair follicle, right, will stimulate those receptors, and they'll send that information up to the central nervous system. So you know that the hair follicle is located down in the lower layer of the dermis there, in the reticular layer. All right. So if like the wind blows and it moves the hair around, it's going to trigger, all right, these nerve endings, all right, to be stimulated to send a nerve impulse up to the spinal cord and brain there. So their job is to detect any type of hair displacement. And we're dealing with our phasic receptors. So these adapt, all right, slowly. All right, then we have our tactile discs, also known as the Merkel cells. So if you recall, when we were talking about the skin and the layers of the skin, we've talked about the epidermis and how you have 4 to 5 strata, depending on whether or not you're in thick skin or thin skin. But the deepest layer is called the stratum basale. And the stratum basale contains 3 different types of cells. Keratinocytes, which is the most abundant, but we also have our melanocytes that produce the coloration to our skin. And then we have our Merkel cells or tactile cells. These cells here are touch cells. So they are actually epithelial cells that sit in that basal layer there. And what will happen is, all right, if you were to apply some pressure or touch, all right, to those cells, they're going to release their neurotransmitter onto the tactile discs. So they respond to light touch, and they are tonic in nature. So if you look at the pictures here, you can see all the different types here. Here's our free nerve endings. All right, so you have, here's your sensory neuron, and then you can see how they're giving off all these different endings here located in various regions. Again, mainly they'll transmit pain and temperature information, but they will provide some touch information too. Then we have our root hair plexes. You can see how they wrap around the hair follicle. So if wind's blowing the hair, it'll cause some displacement there, and it'll trigger the nerve signal here. And then finally, we have our Merkel cells, or the tactile cells. Again, they're going to be in close contact to the tactile disc. So when you are touching something, you'll distort the plasma membrane here. It will release, right, its neurotransmitter onto the tactile disc, and then activate the tactile disc and that sensory neuron for light touch information there. All right, so that's the unencapsulated tactile receptors. Let's take a peek here at the encapsulated tactile receptors. All right, so encapsulated is exactly what you would think it would be. All right, the nerve endings are going to be covered by something. And so there's a choice. You can either have the nerve endings wrapped up by connective tissue, or they can be covered up by, it's like when you wrap a present, do you want to just have wrapping paper on it, or do you want to have wrapping paper and a bow? All right, so our nerve endings can either have connective tissue, or they can have connective tissue and glial cells. In the peripheral nervous system, we know what those are, those neurolemmacytes. Those are the Schwann cells there. All right, so you have a choice, just connective tissue or connective tissue and, all right, so neurolemmacytes there. So the first type, all right, are going to be our end or Krauss bulbs here. And so they're just covered with connective tissue. And so in this situation, we're going to see them in the dermis, also located in our mucous membranes. And so they'll detect pressure and low frequency vibration. Whereas the next type of tactile receptor, We've seen these before when we were going over chapter 6 for the skin, the Pacinian or lamellated corpuscles. Lamellated is layered like an onion, right? So these type of tactile receptors are going to have, all right, connective tissue and neurolemmacytes covering, all right, the actual tactile receptor. So you can actually see the layers there. I'll show you a picture here. So we'll see these down deep in the dermis. Right? Again, down in that reticular layer. We'll also see them possibly in the subcutaneous layer, the hypodermis, and inside of some of our viscera. So the lower you are, the deeper you are in your skin, all right, how I always remembered it, if the receptor was down pretty deep in the skin in the lower layers there, it was going to detect deep pressure. And if the receptor was closer to the surface of the skin, it would be more like light touch, and sometimes we describe it as discriminative touch. All right, so when we're talking about the Pacinian corpuscles, because they're deep in the dermis there, it's going to be deep pressure, coarse touch, and high frequency vibration. Then we have our bulbous or Ruffini corpuscles. These are only wrapped in connective tissue, CT. We'll find this in the dermis and also in that hypodermis or subcutaneous layer. So again, we'll see deep pressure, right, and skin distortion. Like for example, if someone were to grab your skin, all right, and kind of pull it away from your body and then release it, right, that's what we were discussing when we're talking about the skin distortion. And then this should be a familiar face right here, our tactile corpuscles or the Meissner corpuscles. Right, we saw these before too when we were studying the skin back in chapter 6. And again, we're going to see a combination of our neurolemmacytes and the connective tissue covering here. So we're going to see these tactile receptors close to your epidermis. So we're going to find them in the dermal papillae. And you remember the dermal papillae, those were those little bumps that we saw in the papillary layer of the dermis here. And so they're going to be involved in discriminative light touch. So for example, you know, how you're able to tell if something is smooth or rough or furry or slimy, right? It's the discriminative light touch, these tactile corpuscles that help to provide that information to you. All right, so here you can just see the various pictures of these nerve endings here. And when I say that the Pacinian corpuscle looks like an onion, it looks like an onion, like an ogre. It has layers. All right, that brings me into this concept of referred pain. I've talked about referred pain briefly before with you folks. I'm going to go into a little bit more detail. Our textbook definition of referred pain is the inaccurate localization of sensory signals. Well, all right, what sensory signals? What are we talking about here? Is it sensory signals from the skin or skeletal muscle? Or is it sensory signals from the liver, the pancreas, all right, or our intestines? So here's what's going to happen. We're going to get information from an organ, but yet your brother, your brain has a hard time trying to figure out the true source of where this sensory input came from. So what will happen is, right, I'll give you the example here in a moment, but what will happen is an organ is going to be sending sensory input, but your brain will perceive that information coming from a particular area of your skin or a particular skeletal muscle or muscles. So here's the problem. What we see is a lot of somatic sensory neurons and visceral sensory neurons, all right, share the same ascending tract within the spinal cord. And so that sensory information that comes from two different areas or structures, I should say, travels up the same ascending tract. And then when it arrives into the parietal lobe, the somatosensory cortex, the somatosensory cortex can't tell if that sensory input is coming from the organ or from the actual skin or muscle. So let's use an example here that's listed below. Appendicitis. Well, before I do that, let me mention something. Let's do this. All right, so here you have your appendix. All right, and you'll notice here's the sensory neuron coming from the appendix, and it's traveling up through the spinal nerve, and it enters into the spinal cord and ascends up towards the brain. Whereas you'll notice how you have nociceptors located out here in the skin, and they'll send sensory input up to the spinal nerve. And we see how both, right, the sensory neuron for the nociceptors and the sensor in the skin and the sensory neuron for the nociceptors in the appendix, so that's both somatic and visceral sensory neurons, share that same pathway. So what will happen is, even though this is inflamed, right, this area will feel pain. One of the more common examples is heart attack. This happens, all right, where we see this quite a bit with people when they're thinking about referred pain. All right, so when you get a heart attack, all right, you will feel chest pain, normally on the left side, right, but you'll get chest pain in the pectoral region there, and in some cases, left arm pain, but specifically the medial portion of the arm. And the reason why that is, right, it's because, right, the skin in those areas and the nerves, right, that innervate the heart, right, they share the same pathway, right, and they have the T1 through T5 segments of the spinal cord, right. Both of those share the same innervation. So when you're having a heart attack, you'll feel that. Kidney stones, right? Quite often you'll see when people complain of kidney stones, and that includes ureter pain because the kidney stone has to travel down through the ureter, they'll complain of pain in the inferior portion of their abdomen, but specifically in their back. So a lot of times people will complain of having low back pain. And so we go through the whole physical exam process and the patient interview. We ask them what their problem is, and they don't give you any specific reason. What causes pain? Were you moving a couch? Or no, nothing. I don't have any idea. I was just sitting there. I've been sitting all day. I wake up the next morning, and now I have this horrible pain going on. So then you ask them, all right, well, does anyone in your family have kidney stones? Or have you ever had kidney stones? And they say, well, come to think of it, my dad used to get them all the time, but I'm much too young to have kidney stones. And that's usually when I say, you need to get an ultrasound and have that checked out just to make sure. I mean, we'll take x-rays, but the chances of seeing kidney stones on an x-ray aren't always very successful unless it's a calcium-based kidney stone. All right. And then, of course, one of the things that you should understand too is when we talk about visceral pain, most of the time that visceral pain will travel along the sympathetic nerves. So that's what we see with heart attack pain, okay? That sympathetic innervation to the heart comes from, all right, the T1 through T5 spinal cord segments. All right, again, and those are the same segments that will receive that somatic sensory information to the skin. So now when we're dealing with some visceral pain, it's predominantly going to be the sympathetic nerves, but in some cases, the parasympathetic nerves will take over, all right, or will be in lieu of the sympathetic nerves for certain organs. For example, the bladder and your rectum, all right, are both innervated by the parasympathetic nervous system, S2 through S4. So in that scenario, bladder and rectum, it will use the parasympathetic nerves instead of the sympathetic nerves. So this map here just kind of shows you a general map of some of the common sites for referred pain. For example, here you can see, here's your heart attack pain, all right, chest pain, medial arm pain. Right? A lot of times, very common when I've talked to people that have had gallbladder issues, they'll get right shoulder pain. they'll get back pain on the right side of their low back. Stomach, pancreas, normally I've seen more pancreatic pain more through the middle portion, not so much off to the left side. But again, I mean, it varies. Kidney stones, you'll see it down through here in the low back area here, normally towards the flanks. And then you can see how you get the buttock pain for the urinary bladder there. Which brings me to our first clinical view of the evening, phantom pain or phantom limb pain. So this is a scenario in which you see quite a bit with veterans, because quite a few of them, you know, if they've been wounded in combat, they may have lost a limb. And so what will happen is, following the removal of that body part, they are still experiencing, all right, pain, all right, from where that area of where the limb used to be. So you're probably thinking, well, how's that possible? There's nothing there. All right, we've removed, right, that limb, yes. Okay, but guess what is still in place? The pathway. All right, so the sensory neuron pathway is still in place. And as long as, right, the cell body for that sensory neuron is still alive, right, then the pain will still be transmitted. So what we'll do is, usually we just have to do some nerve ablation there and get rid of some of those sensory neurons in that pathway, then problem solved, right? It's not always that easy, but that's one of the scenarios. And for any of you that do know anybody that has lost a limb, amputated, you'll see it with some folks if they're not really managing their diabetes and they've had to take their foot away, or God forbid, you know, take their leg away. This is a phenomenon that they might experience, is that phantom limb pain there. Okay, so let's talk about our first special sense. Well, actually not really our first, because we talked about tactile, but let's get into our sense of smell. It's a good place to begin tonight. All right, so what is smell? Also known as olfaction. Basically, the textbook definition is detection of odorants dissolved in air. So what that statement is saying is, right, you're smelling something out in the external environment. Okay, you have these molecules that are out there that are you're going to breathe in, and you are going to be able to smell, all right, or detect whatever that odor is. So when we talk about odorants, odorants are these, we describe them as volatile molecules. Now, volatile means that they're just very reactive. They interact with a lot of stuff. So these volatile molecules are inhaled, they enter into your nasal cavity, and they'll dissolve right into the mucous membrane in the nasal cavity. And in that mucus there, you have chemoreceptors. And those chemoreceptors are then going to provide us information about whatever it was that you were able to smell. Okay, if it was food, car exhaust, if there's a situation, for example, like somebody that might have bad body odor, okay, it provides you information about that. All right, I have some fears in my life. One of my fears is flying. All right, now, of course, besides the obvious fact, when I fly, all right, my number one fear while flying is the plane's going to crash and I'm going to die. I think everybody kind of shares that. All right, but another fear that I have, and I don't tell too many people about this, is sitting next to a person on the plane that has really bad body odor. All right, that's one of the times where I wish my sense of smell did not work. But the sense of smell can be life-saving. For example, you're lying in bed at night and you wake up in the middle of the night and you smell smoke. And you know what they say, where there's smoke, there's fire. So that sense of smell, that olfaction, can help protect you in dangerous situations. Now, as humans, we're pretty good. I mean, are fortunate that we can distinguish between several thousands of different types of smells. We're not as good as some species, like the dog, all right? But, you know, we're pretty good in that regard there. So as we move through this sense here, we're going to talk about some of the players or the components of our olfaction system here. So first we have to talk about the olfactory epithelium. And this is referred to as our sensory receptor organ. And so the olfactory epithelium is located at the top portion of your nasal cavity. And so we're going to see three different types of cell types in our olfactory epithelium. All right, the first are going to be our olfactory receptor cells. These are going to be the cells that are going to be able to detect the odors that the odorant molecules have produced. And then we have the supporting cells, and of course they play that role of like the glial cells do for the nervous system. All right, they help to sustain, all right, the neurons, where the supporting cells are going to help to sustain and protect our olfactory receptor cells. And then the third type of cell, the basal cells, I call these the baby cells. And because they're the olfactory receptor cells in weight, they haven't quite grown up yet. So usually every 40 to 60 days, the olfactory receptor cells, turn over. And when they do, the basal cells come in and replace those older or damaged or dead olfactory receptor cells. So 40 to 60 days is a pretty decent turnover rate. Problem is, as we get older, all right, that turnover starts to decline. And so we'll have fewer receptors, all right, and then the existing receptors might not be as sensitive to the odorants. And so our overall sense of smell starts to kind of get worse. And you might notice, I've never had a really good sense of smell. But I think my sense of smell has been pretty good. But then again, I'm not quite 50 yet. But again, as you get older, like in your 70s and 80s, you'll see a significant decline in that. So now when you ask, do pregnant women develop more of these, are you talking about more olfactory receptor cells? Yeah, that's true. And so not necessarily more olfactory receptor cells, but the sensitivity of those receptors will definitely increase. And we see that all the time. In patients that I've talked to, my wife also, there were times, a colleague that I work with who's pregnant right now, there's certain smells. Apparently her husband has a favorite morning drink, and I'm not sure if it's his coffee creamer or what, but he's no longer allowed to drink it around her because she gets nauseous around it. And there's still not a lot of clear-cut information as to why that happens, but we do see that the sensitivity of those receptors actually become much more heightened for whatever reason. And I've had some patients and some people that I've talked about when my wife and I had to go in for her OB checkups, that they strongly encouraged everybody not to wear strong perfumes, colognes, or deodorants in the office in hopes to not get anybody ill or nauseous because of those strong smells there. So if you recall, our epithelial tissue will always sit on the basement membrane, but usually deep to that basement membrane, we're going to have the lamina propria. And the lamina propria is just loose connective tissue. But in the lamina propria, we are going to have some of our support structures, right? Blood vessels, right? Nerves, and the olfactory glands. Now, the olfactory glands are going to make the mucus, all right, that's going to cover the olfactory epithelium. We call those Bowman glands. So I'm going to show you a nice picture here. So first, let's look at the picture to our left. And so you can see, all right, as this person brings their hot cocoa to their nose, the odorants from the hot cocoa travel into the nasal cavity. And they'll make it up to the superior portion here. And up in here, you'll have a layer of mucus. But what I'm displaying to you is, all right, you're seeing the olfactory nerves here in the superior region, and they come off of this structure called the olfactory bulb. Now, the olfactory bulb and the olfactory tract are found in the cranial cavity here. And what separates them is this layer of bone. And in this layer of bone here, there's these holes here. And so in this region here, all right, that is called the cribriform plate. The cribriform plate is part of the ethmoid bone, and it has the olfactory foramina. And as you recall, a foramina is a rounded hole in a bone. So it has all these little tiny holes that the olfactory nerves travel down inferiorly from the olfactory bulb out here into the superior region of the nasal cavity. Now let's take a close look at this structure here and zoom in. And we'll start here at the bottom of our page. So this part here is out in the nasal cavity. All of this is in the nasal cavity. So here is your mucus layer. So this is where the odorants, all right, when you're smelling, all right, will get lodged in. And you'll notice also in the mucus layer, we have our olfactory hairs. They're just cilia, and they have chemoreceptors there. So these odorants are going to react with those chemoreceptors. Here in our olfactory epithelium are those three different types of cells. Right? Obviously, you're going to have your olfactory receptor cell, and it's a bipolar neuron, which means you have a cell body and you have a process coming off one way and a process coming off on the other side here. So here's the cell body. This process is going to be the dendrite, and it's going to have the little cilia at the terminal end here. And then going back, here's the axon. Then you can see the supporting cells. They kind of help hold the olfactory receptor cells in place. And then here are our little baby cells, the basal cells. They're just waiting to fill the place of the olfactory receptor cell, right, when it's its turn. Then deep to the olfactory layer, here's our lamina propria. This is where we're going to find the nerves here. We'll also find our Bowman's gland here, and then blood vessels. Then our cribriform plate. And then just above it, sitting on top, is the olfactory bulb. So this is where the olfactory receptor cell, the neuron here, it'll synapse onto these other two cell types called the mitral cell and the tufted cell. And where they synapse, we refer to as the olfactory glomerulus. Now, we'll talk a little bit about all this stuff here, but I just kind of wanted to point these structures out to you. Okay, so back to the olfactory receptor cells. Remember our neuron chain for sensory input up to the central nervous system? You're always going to have at least two, all right, neurons in our neuron chain. All right, so in this scenario here, where we're talking about our sense of smell, the first neuron that we talked about, we called it the primary neuron or the first order neuron. So olfactory receptor cells are our primary neurons. And so they're going to start off our pathway for smell up to the central nervous system. So at the very end of these primary neurons is where we're going to have our cilia, which house the chemoreceptors. Now they're odorant specific, meaning, all right, if you have a chemoreceptor that's specific for something that smells sweet, if you're just smelling something, all right, that is, I was going to say vulgar, but like car exhaust, for example, those chemoreceptors won't pick up that odorant of the car exhaust. If you were to smell something, you know, that was like a flower or a cake, then those chemoreceptors, all right, would perceive that smell. Okay, so it depends on which chemoreceptors are going to be stimulated, all right, and that's based on what type of odorant that they come in contact with. All right, so when we were going over our cranial nerves, we learned that the first cranial nerve is called the olfactory nerve. And I told you how I remember that is that you only have one nose. Okay, so the cranial nerve number one, olfactory nerve, is going to be based in the nose. So here we're going to see our olfactory going back here. All of this is our olfactory neuron, or nerve, I should say. All of those. All right. So basically, when we talk about the olfactory nerves, we're talking about, all right, all of those axons there that are traveling through the cribriform plate and going to synapse in the olfactory bulbs. Now, keep in mind, you have a left and right olfactory bulb, and the olfactory bulbs are often confused with the cranial nerves. But here's the thing with the olfactory bulbs. The olfactory bulbs are usually parallel to one another. Right, so if you're looking at the inferior view of your brain, the olfactory tracts run parallel to one another. Whereas the cranial nerve 2, the optic nerves, go at an angle and they converge at the optic chiasm. Often confused. But the olfactory bulbs are going to be found on the inferior surface of the frontal lobes. And it's here where the olfactory nerves, right, our primary neurons, are going to synapse with the mitral cells and our tufted cells. And where they synapse, like I said, is the olfactory glomeruli. And then from there, from the olfactory bulbs, right, we project our secondary neurons, right, back posteriorly towards our olfactory cortex in the temporal lobe. So our secondary neurons, our mitral and tufted cells, they're going to project posteriorly, all right, along the inferior portion of the frontal lobe back towards our temporal lobe, where our primary olfactory cortex is located. But not only that, right, some of those neurons are going to travel to the hypothalamus to elicit a visceral reaction, like you smell something that's very delicious and your mouth starts to water. You can thank the hypothalamus for that. And especially if it's something that you like and smells good, well, then, and it puts a smile on your face, then you can thank the amygdala, all right, because we're involving the limbic system in that. And also the amygdala helps us to recognize the smell if we have a memory of it. But this is an important point right here. All right. The sensory pathway for olfaction does not go to the thalamus. The others do, but olfaction does not. That's a great test question, so please don't miss that. So how do we smell stuff? How do I smell things? Here's what happens. You take a breath in or you sniff something quite a bit, and those odorants enter into your nasal cavity and they lodge themselves into the mucus. In the mucus, you have these proteins called odorant binding proteins. And so they will attach themselves to these odorants here, and they'll travel to the receptors, the chemoreceptors there. And they are going to set in motion what we call our secondary messenger system. You'll learn more about this in detail in 211, but for right now, let me just give you a quick analogy as to how that works. All right, I have a message for you, and I want to give you that message. So I come to your house, I knock on the door, you are indisposed. So you have a butler or a servant or whoever, and they come to the door without opening the door, and they ask me, may I help you? I say, I have a message for so-and-so. I'd like to give it to them. They say, no, they are indisposed. You cannot come in. Give me the message, and then I will give it to so-and-so. And that's basically what happens. So what happens is, all right, you have these receptors, and you have this protein attached onto the receptor on the inside of the cell called the G protein. Well, once we activate that receptor, that G protein is going to activate this enzyme. It's called adenylate cyclase. That's going to convert ATP into what's called cyclic AMP. Cyclic AMP then triggers the opening of sodium and calcium ion channels. Look at those two molecules there. Look at those two elements. They're cations. So they rush into the cell. They make the inside of the cell more positive, essentially depolarizing the cell. Guess what we've just done? We've created an action potential. And that's how, all right, smell occurs through the secondary messenger system. The action potential then travels down our primary axon towards the olfactory glomerulus. Well, then we have our primary neuron synapsing onto our secondary neuron. That secondary neuron, all right, the neurons of the mitral cells and the tufted cells are going to travel to various areas in your central nervous system, right? It'll go to the temporal lobe in the cerebral cortex, so you can actually perceive that you're actually smelling something. And if you have a memory of it located in the cerebral cortex, you'll be able to identify the smell. All right, some of those secondary neurons will travel to the hypothalamus and give you a visceral reaction to that smell, like salivation. It'll start up the stomach. Okay, hey, I think it's time to eat. This smells like food. Let's get the stomach online. Let's get, some of those digestive enzymes flowing so we can start to digest, because I think it's about time to eat. And then, of course, the amygdala, if it's something that you're really liking, you get that emotional reaction of giddiness there, right? You're like, I can't wait. And it also helps with smell recognition. All righty, folks. I think what I'm going to do is stop here for now.